let's look at what will go wrong, the complications. If you don't treat a urinary tract infection appropriately, what could possibly go wrong? So if you don't treat it, the urethritis can become a cystitis. It can ascend up and become an acute pyelonephritis. Acute pyelonephritis is a life-threatening situation. Acute pyelonephritis, if not treated, can get converted to an abscess, or the whole kidney can become a bag of pus called pyonephrosis. Or they can develop chronic pyelonephritis, which finally leads to CKD and elevated creatinine, then dialysis and transplant. If it's untreated, it can spill over into the bloodstream and cause gram-negative sepsis, what we call urosepsis. Frequent infections can cause defects in the urinary tract. So it can cause either strictures or some other disorders, and that will predispose them to more and more infections in the future. And one of the most dreaded complications of urinary tract infection is papillary necrosis, where the pyramids of the kidney get infected, they start sloughing off, they come into the ureter, into the bladder. Sometimes they block the ureter and they cause obstruction, and they can cause renal failure, AKIs, and they can even cause death, because if they're all obstructed, they can bleed, flank pain, fever, chills, urosepsis, shock, and then that's the end of the story. Papillary necrosis is common in those who are alcoholic, diabetics, those of sickle cell disease, and those of vascular disease, and also something which all of us need to know: NSAIDs and COX-2 inhibitors can predispose to papillary necrosis. Somebody who's got a UTI, you do not want to give them NSAIDs or COX-2 inhibitors, because there's a possibility that that UTI can become an ascending infection, cause papillary necrosis, and that can get worse with COX-2 inhibitors and NSAIDs. And we already know these medications can cause renal insufficiency. So it's a double whammy. You can get infection that can cause papillary necrosis, it's precipitated by the NSAIDs, and NSAIDs themselves can cause AKI. How do we treat urinary tract infections? This is, I'm sure this is what everybody is looking forward to and looking forward to understanding. We have to categorize. That's the whole point of this lecture that I've been giving, to understand what kind of infection it is, the location. So if it's an uncomplicated lower urinary tract infection and the woman is not pregnant, if we're talking about women here and she's not pregnant, the first line would be either Septran, but of course the decision of the antibiotic is based on the antibiotic susceptibility in your particular hospital or your particular city. And we don't use Septran DS in our hospital much. We would rather go for nitrofurantoin. So nitrofurantoin, if you want to give it as first line, would be 100 milligrams twice a day for 7 days. If you're going to give fosfomycin, it will be a single dose. But most studies and data have shown that single dose of fosfomycin is inferior to either nitrofurantoin or Bactrim or Septran in the treatment of UTI. So if I had a choice, I would go for nitrofurantoin, provided there's no contraindication to it. Sometimes there is a contraindication, for which, in which situation you go to second line drug, which would be a quinolone. So either Cipro 250 BD or levoflox, and this or ofloxacin, and this treatment would be for at least 3 days. Now remember, after you start the antibiotic, it is not necessary that after 3 days the infection will go away or the symptoms will go. Sometimes the symptoms can last for 5 days. That doesn't mean you need to prolong the antibiotics and continue it for 5 days. If it is simple, uncomplicated lower urinary tract infection, you can just give 3 days. And even if the patient is symptomatic after 3 days, don't continue the antibiotics for a longer period of time. Now, ciprofloxacin and other quinolones are a good choice because they're one of the few drugs which do not knock out the lactobacillus. Remember, lactobacillus is the normal commensal and it helps protect the urinary tract from other enteric bacterial infections. So quinolones are a good choice because they don't allow, they don't knock out the lactobacillus. Plus, they have a broader spectrum of coverage. And mostly in our practice, we use a quinolone as first line itself instead of waiting for nitrofurantoin and then using quinolone. For men, the same antibiotics, but it will be for a longer duration, for at least 7 days. So this is for an uncomplicated lower UTI. If you have a complicated UTI, what do? And what do I mean by complicated? By complicated, we mean either an abnormal patient or an abnormal bug or an abnormal tract, abnormal urinary tract. So by abnormal patient, I mean somebody who's immunosuppressed. So somebody who's a diabetic or a post-transplant patient, or somebody who's got some collagen vascular disease or a malignancy patient. So these patients are considered abnormal patients, not really abnormal in that way, but abnormal from a urinary tract infection point of view. So they will have complicated UTIs. Abnormal bug. So Pseudomonas is not a common bug for infection, or MDR, Klebsiella, MDR Pseudomonas, or staph epidermidis. These are not common bugs. So they're affecting the urinary tract and causing infection. That is abnormal, and that's considered a complicated UTI. And abnormal urinary tract. So somebody who's got stones or hydronephrosis or a stricture or has had some instrumentation, these are all abnormal urinary tract. So these are considered a complicated UTI. And even if it's a lower UTI, it's still complicated. So we need to give antibiotics, higher dose of Cipro for 7 to 14 days. Or if you're going to give Levo for 5 days. And if they're pregnant, we have to, for pregnant women, any kind of infection, whether it's complicated or uncomplicated, the first choice would be nitrofurantoin 100 BD for 7 days, or augmentin or cephalexin. Fosfomycin is not a very good idea, though the textbooks do mention it. If you're looking at an uncomplicated pyelonephritis, either a quinolone or an aminoglycoside or a third generation cephalosporin, at least for 14 days. Initially IV, then you can switch to oral once clinically they're better. 14 days, that is the bottom line. So that's the differentiation between our upper tract and a lower tract. Upper tract treatment for 14 days, lower tract for 3 to 7 days. If it's a complicated UTI, we already discussed what are complicated UTIs. Start off with the quinolone and then do the cultures and give antibiotics for at least 21 days. Sometimes we need to give chemoprophylaxis where somebody is getting recurrent infections. So we need to give some low dose antibiotic for a long period of time. What we do is the standard dosing of the antibiotic, we reduce it by 1/4 and we give it at night. So suppose the treatment of the UTI is nitrofurantoin 100 BD. So we make it 50 mg at bedtime. The reason why we give it at bedtime is because people don't drink water while sleeping. So the flushing mechanism is not there. And there is most people don't get up to pass urine. So there's stasis of urine. So the chances of infection are more at night. So these medications are given in the night to prevent it. So what are the principles of treatment? How do we really summarize all this? First thing, when you suspect a urinary tract infection, decide whether it's upper or lower, confirm the infection by sending cultures, start the treatment, modify treatment based on the culture reports. Also rule out a complicated UTI like obstruction, calculi by doing ultrasound or X-rays or CT. Remember, even if they're symptomatically relieved, it doesn't necessarily mean that they're cured. Cure would only be if there are absent symptoms and the culture is negative again. So the point I'm trying to make is culture needs to be repeated again, even after treating them. If there's asymptomatic, do a culture 3 days after completing the course of antibiotics and confirm that the infection is not there. And if they're uncomplicated infections, it's a short course for 3 to 7 days. If it's a complicated upper tract infection, long course of 14 days. If it's complicated, 21 days. And community acquired usually are easily susceptible to the standard antibiotics. One quick look at the relapse. What it means is if the same strain of bacteria causes an infection within 2 weeks of cessation, that's a relapse. Reinfection is by a different bacteria. And often, if there are multiple bacteria, then it's likely to be a contaminant. Renal TB, I don't think we have time for this. We can leave that to another session. One quick thing on fungal infections, Candida is often the commonest one, and the definition will be if there are 10⁻³ colonies of yeast on 2 consecutive cultures, often seen in catheterized hospitalized patients, and it's common in those who receive multiple antibiotics. Treatment fluconazole 200 mg to start off with, and then 100 OD for 7 days. So this entire presentation is going to be available with Medvarsity, with the website there. And it's also going to be there on my YouTube channel. It's there in case you want to go through it. You can log in there and have a look at it. I'm also sharing it on the chat box, so you have easy access to the link, and you can look at all the other articles as well there. So thank you all very much for listening to me.